Welcome everybody to our webinar today, creating low barrier access to care, but really, because we're going to talk about what the heck does that even mean? We mention the words low barrier all the time, and we really don't spend a lot of time diving into the practicalities of how we make things actually low barrier for our patients. I will introduce our guests in just a hot second here, but first, in case you're new to us, we are the Bridge program. California Bridge is a part of the Public Health Institute, and we are an organization that came together to try to help make access to care easier for patients, in particular for patients who struggle with substance use disorders. None of our speakers today have any financial disclosures, but I'm gonna be real with you, we're gonna say brand names. It's not on purpose, it's not because pharma pays us, it's because our patients say brand names like Narcan instead of naloxone. So if we do it, it's not on purpose or intentional at all, and I do apologize in advance. Again, if this is your first time learning about us, we, Bridge, were founded with the goal to ensure that every hospital across California had low barrier access to medication for addiction from every hospital and ER in California by the end of this year. And I am so excited to tell you that we are doing this. We are at over 275 hospitals across our state in a model that we know works. That model involves three really important pillars. First and foremost, ensuring low barrier access to treatment. And when we say treatment, we mean medication, evidence-based medicines that help people stop using drugs, in particular opioids, since that's the one that's really killing the majority of people in our communities. The next thing, though, is the importance of linking those patients that we started on medication to ongoing care and support in the community. And the final thing is developing a culture of harm reduction, which is both fighting against the stigma that we've built against patients who use drugs over all this time, but also thinking about ways to help our patients mitigate the harms that come from substance use, things like abscesses or HIV or even overdose, any of the kind of things that can harm our patients. We want to get rid of those harms. Today, we are going to do something a little bit new, which is focusing a lot more on this connection to ongoing low barrier addiction care. I am so excited to spend some time diving into this topic because we really at Bridge have focused more on the acute care setting, and we talk a lot about our navigators, but we don't talk a lot about those clinics that then receive those patients from us. Like, what do they do? How do they make sure that they have success? We are going to dive into some concepts today that were first highlighted by this amazing advisory that came out from SAMHSA, the Substance Abuse and Mental Health Services Administration, in December of 2023. What we know is that fewer than 10% of patients with substance use disorder have actual sustained access to care. Fewer than 10%. I want you to think about if only 8% of people with diabetes got access to diabetes treatment. We would never tolerate that. So we definitely have to do better. And in 2021, only 22% of patients with opioid use disorder were given medication. Again, think about if only 1 in 5 people with asthma was allowed to have an inhaler. That would be insane. We would never tolerate that. So we can't tolerate that for our patients who have substance use either. And only 6% of people with drug or alcohol use have ever received any treatment. That's including counseling or therapy or the things that are adjuncts to the medication. So we definitely know these numbers are bad. And the goal here is that we have to build low barrier care, which seeks to minimize the demands that are placed on our clients or our patients and make services readily available and easily accessible to those patients. It promotes a non-judgmental, welcoming, accepting environment, and we provide culturally responsive and trauma-informed care tailored to those unique patients and their incredibly complex stories that we all love to hear and we honor, and we just are really privileged to be able to help them. So all that said, as framing for today, I am an ED doc. So if you're not familiar with me, I'm Alicia Gonzalez. I'm an emergency physician by training. I am the director of clinical training here at Bridge. And I am not an expert in clinic care. There's like not a single thing I would know how to do except for going to clinic and say like, hi, I'm the doctor. Where's the bathroom? I would not know how to do it. So I am joined today by 3 incredible experts, some of my literal favorite people who are doing this. And fun fact, they all started in acute care and then moved into addiction care in the outpatient setting. And I'm just so privileged to have them be able to offer that lens and that information. I will let each of them introduce themselves for you. And I would love to start with Julie. Oh, Julie, you're on mute. Yeah.
Okay, now you can hear me.
Yes.
Hello, everyone. I'm so pleased to be able to get to speak with my colleagues today and all of you that are joining us. So I am also, my background is I'm also an ED doc that's new to the outpatient world, but I bring three different perspectives. I bring the ER doc part of it, where we have a bridge grant a long time ago in the very beginning. So I've got that experience. And then I'm also a medical director at two residential and outpatient facilities, one of which has a long-standing MAT outpatient program, and one we've just put MAT on the residential side, and with the goal and all the plans to put an outpatient clinic there as well. So I've got all of it, like in the preparation side, what do you have to do, and then also kind of the fine-tuning side in a clinic that's already been running really well.
Awesome. Maureen.
Good morning. I too am an emergency physician. I actually was originally trained in pediatric emergency medicine, so I had that great academic career, which I loved. And about 6 years ago, addiction medicine kind of fell into my lap. I got a call from one of the founders of Bridge and said, "You have got to apply for this Bridge grant." What is a Bridge grant? And if you had asked me 6 years ago if I would be running a Bridge clinic, which I do today, I would have said, "You're crazy." So I started in the emergency department, and I now am addiction boarded, and we run a once-a-week Bridge clinic. And I tell you, it is amazing, fantastic. This has been life-changing for me, and I know life-changing for the patients that we help in our hospital.
Absolutely. Taylor. Oh, Taylor, you're on mute too.
An emergency physician by training. I subsequently did training in and got board certified in addiction medicine, and I'm now the medical director of an MAT clinic here in Sacramento, California. We were always sort of a low barrier model, and I've worked to sort of decrease those barriers further. One of those things that we're doing now is I've worked with the EMS medical directors from Sacramento City and County to become an alternate destination where patients can be dropped off directly to our clinic during business hours by our overdose response team and our homeless outreach teams. If patients are seeking treatment or they want treatment, including after an overdose, they can bring them directly to us. We do take drop-ins either way, but so now we take drop-ins by EMS. And we also, what's that?
Go ahead.
We also are working on having patients be able to start on long-acting injectables from their first appointment. So we're trying to drive down barriers, including to long-term treatment for patients for a full scope addiction treatment.
I love that in each of your introductions, you are already talking about specific examples of what we would call things that are low barrier. But I want to think about something that I know about the clinic setting, because as a patient in this world, I have encountered this, which is thinking about scheduling and appointments and those kinds of things. I feel like that's an item that even I, as like a person who doesn't have substance use disorder, but I'm busy, I have a really hard time like getting to my appointments and getting there on time and scheduling an appointment within 6 months of me trying to call for my annual exam or whatever. And so I want to talk about that first. What are some things for us to know about the structures of each of your clinics? Because I've already heard you say things that don't sound like appointments to me, drop-ins, EMS arrivals, that kind of stuff. So maybe Taylor, we could start with you. Tell me a little bit about the structure of your clinic. How are patients arriving there, scheduling, not scheduling there? What does a day look like in the quote unquote schedule of your clinic?
We do have a schedule, a clinic schedule. We have patient appointment slots between 8:40 and 5 p.m. But we are pretty flexible with that. Our goal is to make it easy and convenient for patients to access our clinic. And like I said, we accept drop-ins, so there has to be some built-in flexibility there. And patients have to understand that sometimes things get shifted. We partner with this School of Medicine, and medical students, residents, and fellows, addiction medicine fellows rotate through with us. And one of my favorite quotes about our clinic, I had an addiction medicine fellow who was family medicine trained, was rotating with me, and she after a few days sort of said, it seems like you guys view the schedule as more of a recommendation, which is sort of one of my favorite ways to frame it. It's like, yeah, we're flexible. We're trying to meet patients where they're at. We're doing telehealth appointments. A lot of our patients are at work and they can take their break. We try to coordinate with them and we make it easy for them to reach us. So we have a text platform that they can just text the clinic on. If they're running late or if we're running late in terms of our schedule. So if patients are late, we'll still see them anyways. If we have them scheduled.
Yeah, it sounds like we're having a little bit of internet issues continue to Taylor, but that's
They
okay.
can't make it. We'll still accessible and being scheduled.
Yeah. Aiden, if we could just mute Taylor really fast. So what I'm hearing Taylor say is that, yes, of course you have scheduled appointments, but you want to make sure that you have ways for patients, like if they're late, that they can still be seen. If they want to do a telehealth visit, that they can, that flexibility. Julie, I know when we prepared for today, you were talking a lot about like how we communicate with patients and what that might look like. So can you elaborate a little bit more on this idea of what the schedule is, but how you do that communication?
Yeah, sure. It really, it's an old-fashioned way of calling is really the first way, right? And hopefully our navigators or whoever our caseworker management people have gotten them a phone so we can have easy access to them because that's a struggle for most of our patients. But I think really like texting is the way, right? That's what we all do. It's not a phone call. Like we miss phone calls all the time, right? Like I see it later, and then the phone message just pops up 2 hours later. So just texting is really great, and that works for them. I think a lot better. And then also the follow-up. So if you lose track of a patient, or even if they missed an appointment, have a tracking system. Have a dedicated person in your office to call. If it's not yourself, then a backup person to make sure that they're not having any struggles. Can we help them get there? Can we Uber them there? That kind of a thing. So I think the navigator, clinic manager, all those are super, super important. And then really telehealth. So telehealth is going to be the way, right? So initial appointments, yes, we need to see you. Yes, there's drug screening, all the details we'll talk about, but we need to have a telehealth available, which is a great platform for substance use recovery. It works so well. It's evidence-based treat is really proven that this will work. So I think that's the way to go, is bring us to them rather than them having to come to us.
Yeah, I'll tell you, if I could do my annual every year during my lunch break at work, I would be a much more compliant patient. I think I would do a
100%.
much better job of showing up in general. But I mean, I also love what you're saying about the texting, because that's real. Like, how many spam calls do we get every day? And so if you can have a dedicated number from your clinic where you text, hey, it's Dr. So-and-so, or it's the navigator, this person that you know. We noticed you didn't come to your appointment. Do you have time later today? Can we connect anyway? Are you available right now? Can you drop in after work? Like, what's up? Do you want to come tomorrow? That instead of firing patients or punishing them for not coming, that we say, hey, we're interested in this. We're still here for you. Can we reschedule? That makes me think, I kind of want to pivot a little bit and think about medication access, because I will say that in thinking about scheduling, I have heard of many clinics who have like a lot of rules, right? That if you want medicine, you have to come in person, or you have to, meet these certain number of requirements. So Maureen, let's try you. What are some things that you're thinking about or that you're doing in your clinic to address medication access and to prioritize that? What does that look like for you?
Yeah, so I think you brought up a good point. Like, I jumped into addiction medicine with already understanding the low barrier. That means I had to understand the high barriers. And it's exactly like you talked about, that patients had to have labs and urine. In fact, I just talked to a clinic the other day that they require labs and urine drug screening before they prescribe the medication. There is no contraindication, either labs or urine drug screening. If they're positive in their urine drug screening, they actually need the medication. So, it's understanding what the roadblocks prior really makes you more appreciate the low barrier. So some of the things is, the phrase is meds in mouth. We want medications in the mouths of patients as soon as possible. Lower any barrier. That means getting meds on the first day. Obviously, starting in the emergency room when the patients are at their most vulnerable, they've just had an overdose, is key. And that's where Bridge has been really, really powerful. Not requiring labs. Not requiring urine drug screens before you write that first prescription, not requiring a second visit. Like we're asking patients to kind of earn the privilege of treatment. And we would never do that with asthma. We would never say, you've got to come back on a second day for me to be able to write for you an inhaler or write for steroids. So it's really writing for meds that first day, not requiring a daily visit. One of the things that clinics, the way they make their money is by having in-person visits, right? That makes more money if you have a person come back every day than here's a script, I'll see you in a month. Doing those daily visits is not a patient-centered approach. We don't do that with any other chronic disease. And that's where we need to elevate this. Not mandating counseling. Obviously, counseling can be an adjunct. You know, if your life is in such a disarray, you've lost your family and your job and your kids, you probably do need to talk to someone about it. But we know that medications alone work. You do not mandate counseling. It's good to have it as an adjunct, but you should not be mandating it. And then also understanding the era of fentanyl. I've only been doing this for 5 years, and fentanyl has obviously completely pivoted how we think about Suboxone and buprenorphine. If you talk to people that have been doing this 10 or 20 years, they probably started with 2 milligrams, 4 milligrams. We routinely start with 16, 24 milligrams. And understanding that patients with fentanyl are probably going to require higher daily dosage. We would never say to a patient who is insulin dependent, hey, we're going to limit the amount of insulin that you need. You know, there's a cap. That's ridiculous. We never do this. And we need to take that same approach. It's a chronic relapsing brain disease. I kind of call it the ugly stepchildren of, you know, chronic disease, that and pain management. And it really needs to rise to the same level of resources and research and funding as strokes and heart disease and all the other diseases that get a lot of attention in this country.
Yeah, I wish I could have just like captured everything you just said and make it into a snippet that I can show to every physician across the country, because it was such a good, you know, summary of things like emphasizing medication immediately and really thinking about addiction as a chronic disease, that we wouldn't make patients earn access to care for anything else, and that there really is no medical contraindication to any of these things. So mandating testing, et cetera, up front is also just absolutely bananas and not necessary. Which kind of going back to thinking about the telehealth, we brought up telehealth as a concept. And I know that I'm a big believer in the importance of access to telehealth. I don't think it's the right thing for everyone. I think it's an important thing for patients to have the option, right? Some want to come in person, some want to do telehealth. It must be part of our low barrier approach. But when we think about like requirements or how that works, I don't know anything. Like, besides, I guess I could call a patient on the phone and like put in my chart, I talk to the patient. Is that telehealth? Like, I have no idea how that sets up. And I do know there are a lot of emergency or acute care clinicians or hospitals that are trying to find a way to reach patients and might be interested in this. Taylor, you mentioned doing a lot of telehealth as a part of your clinic experience. Can we start with you? Like, walk me through a little bit. What is the general stuff, without getting into the 48-hour webinar version of this, but what is the general stuff about telehealth that somebody who wants to get started doing this for patients would need to know? Oh, you're on mute, sorry.
We're fortunate now that we are able to use telehealth tools as a means of delivering care.
Yeah.
The important things to know are that the delivery of the care is at the place that the patient is located. So if you're licensed in California, the patient needs to be located in California. But under these guidelines, you can provide telehealth via video visits or audio only for even the prescribing of controlled substances like buprenorphine. So you can do that now with so the DEA issued a final ruling on the expansion of telehealth. They issued the ruling in January, and that allows for 6 months of prescribing of buprenorphine from even just an audio only telehealth call to initiate treatment.
Wow.
Now, after that 6 months, the patient either will need to do an in-person visit, or the DEA and the DOJ have proposed a special registration system that would allow patients to receive prescribed controlled substances through telehealth visits without having to have an in-person visit at all. So that's open right now. Actually, the last day for comments is today. So they are going to create this special registration for the providers. So for these telehealth only platforms or for the individual providers to be able to register so that your patients don't even have to be seen in person. If you are not a registered provider in one of these special registrations, then your patients will need to be seen at least once ever. That can be for their initial visit. So like in my clinic, we take walk-ins. Most of our patients started with an in-person initial visit. That would count. From that point forward, you can have all of the rest of your visits can be virtual. They can be via telehealth tools with audio only or video visits. So that allows us the flexibility to continue to use these tools that give us the opportunity to keep these low barriers for treatment. I mean, I certainly wish that all of my appointments could be telehealth, and I can't tell you, I haven't actually been into my doctor's office. I had the same doctor for a few years, and I've only done telehealth visits with them, and it's been incredibly helpful for me. And I can't imagine if I had to do one every month or however many times per year that a patient may have to do that for just to access their chronic treatment. This is such a critical tool, and we utilize frequently from my clinic. The other aspect of that is that it allows patients to continue to be in touch with us. By being able to utilize those tools, by being able to have text platforms and even do audio only visits, that phone call that they want to just follow up, we can record as a patient visit.
Nice, nice. And I know I want to just point out something, and then actually, Maureen, I have a different question for you in general, but I know that Maureen, at your clinic, you had a really creative and effective solution that has worked for this in-person visit. Do you want to share what that is?
Yeah, so I work for a large organization. I'm in LA County, and we have access to Brian Hurley. Brian Hurley is currently the president of the board of directors of the American Society of Addiction Medicine. So we feel like we have a colleague, we have a partner who's close to the ear of DOJ and close to the DEA. And we decided, we're a large organization. We have 3 acute care hospitals. We have a rehab hospital, multiple clinics. And we decided, we started in our addiction work here in LA County with the 3 emergency departments. And so we've been prescribing buprenorphine now for 6 years. And we decided that that in-person visit, the ER visit, was going to count as that in-person visit because they're being seen by an ER physician who is, has a DEA certification. They can prescribe buprenorphine. And we use that as the in-person visit. We've never been audited. And as far as I know, there's actually had not been any auditing of this rule across the country. Right. So you can tell we're probably in the ask for forgiveness, not permission category, but it works for us. And we believe that it meets the letter of the essence of the law that is.
Yeah. I think it certainly meets the spirit of the law in the sense that what we're trying to say is that there, at some point, if a patient's going to be on a controlled substance, which buprenorphine is, we ought to have a face-to-face encounter where someone meets this human and says, gosh,
yes,
yeah, this is the right thing for you.
Right.
And, I'll take this as an ER doc. I have that ability. I promise. I'm good at that. I can do that. I'm happy to be that in-person touch point. And we have worked so hard, all of you on this call probably, but have worked so hard to build these programs in your emergency department. Yet another way that is a success marker for the patient, right? If you are seeing the patient in the ED, or heck, if your patient can't make it in person to clinic because their work schedule, whatever, just go to the ER. Go to the ER. That's what we're here for. We are the safety net. We can help everybody 24/7, 365. Come see me in person. Let's get you on medication. Let's continue that care. I love that. So Maureen, thinking a little bit more, I would love to talk a little bit about your actual starting your story.
Sure.
It's the story of your clinic, because I think that when we, for example, I've worked in hospitals where we want to have a addiction clinic or an ongoing substance use care clinic, and everyone kind of panics. Hard. It seems so intensive. But when I heard your story, I was like, oh my gosh, this is the emergency department doctor version of how you start this. So share what you did as an example of how somebody who wants to do this care could start in their system.
Yeah. So again, the grant fell into my lap, and I work at a hospital that's this big and has this number of patients. So there is 0 space. So we basically started in the back of our urgent care. We did get into our EHR. We did make scheduled appointment ability. So we call it MAT Bridge, is the ability to schedule patients. We started in the back of urgent care, literally had a chair. We didn't use any of the urgent care staff because we started small. We started with just refilling buprenorphine. We didn't do injectables. We didn't do alcohol use disorder, all of which we've now pivoted to. But in the beginning, we kept it very, very simple. So we'd call our own patients in. We had a navigator who was able to call the patients before, but it literally was a chair in the back of urgent care.
Nice.
That lasted for about 4 months, and then COVID hit. And we immediately pivoted to telehealth. And we've been exclusively phone visit up until about a year ago because of the lack of physical space. We now have some physical space, but most of the calls that we do, most of the visits we do has been everything that we've already spoken about. They're all phone visits. We text patients. We're able to recall them. A couple other things I think you have to think about when starting a MAT clinic is you got to make sure that your EHR, you got to be able to document the visits. There is a federal law called CF42, which is very arcane. We all hate it. And it basically says if you are getting treated for addiction over here, everybody else in your healthcare world can't know about it. There's like this firewall between. And so you can't call it addiction medicine. You can't write on an addiction note in your general EMR. And so what we do is we don't call it addiction. We write on a consultation note. You could write on a clinic note, something that doesn't have the word addiction in it. The visits don't have the word addiction in it. I don't call myself an addiction provider. I call myself a bridge provider. And so you just need to make sure that what you're talking about is medications. That's what your clinic is all about, medications. We offer counseling, but it's separate from our clinic. It's with our social work department. You need to make sure that your hospital, obviously, you want to get paid for this, right? You may not in the beginning, but you want to start scheduling patients. So you need to make sure your hospital can do the billing. You need to make sure they understand the SUD, ICD-10 codes. And if you have a HEDIS measure, such as FUA and FUI that your hospital is following, which is, that's here in California, it's paid under DHCS, where hospitals can get money if they have follow-up visits within 7 days and 30 days for anybody that's been in the ER for some type of substance use disorder. You can get those clinic visits, those bridge clinics, to count as toward the HEDIS measure. And that's another way, another revenue bringing into the hospital. You want to make sure that you have malpractice coverage. I think we talked a little bit. We're going to talk about some HIPAA compliant ways of calling patients. So obviously, clinic visits have used telephones and video visits. So you probably can just engage in that already exists in your hospital or in your clinic. And then things like Doximity. I think somebody's going to put something in the chat about Doximity. Doximity is a third-party vendor. We don't have any, federal or have any like financial say in them. It's just the app that we use when I make phone calls when I'm out of the hospital. I will use Doximity. If you're going to have medications, obviously you have to think about medication storage. If you're doing this already in an existing clinic or your hospital, you can just kind of tap into that. But I think the biggest thing is start simple. You don't need to be huge and all-encompassing from the beginning. Literally just start with refilling Suboxone buprenorphine prescriptions. Start small. That would probably be my probably takeaways from that. You don't have to add injectables. Don't need to do other substance use disorders. Start small. If I can do it, having done emergency medicine and PZM for 20 years and completely pivoted without having gotten yet, board certified, it's great. It's
nice.
Easy to do.
And I do want to, there was a question in the chat that I really appreciated, which was asking, does every clinician who sees the patient in a clinic like that have to be addiction board certified? Can it be an emergency doctor?
No.
Yeah. And I want to just point out, any of us can do this. Like, you don't have to be addiction board certified. So yeah, use your ED team, use your, your doctors and your PAs and your NPs that are interested and passionate. You can learn this. And also I want to put out a quick call out that if you are interested, this is the year where the practice pathway is going to close for addiction board certification. So if you want to do your addiction boards and you're a doc, separate conversation, reach out to us. We're happy to support you through that. Julie, can you talk a little bit more about for telehealth specifically, at least at first, because I'm thinking about multiple issues that are coming up, like calling the patient, them contacting us, urine drug screening, which we're going to get into a second. Don't worry, Dylan, man, I see your comment in the chat. We're going to get right to it.
Yeah.
Talk about telehealth in the context of those items.
Sure. So telehealth, so you just have to have a way to call them, right? So most people don't want to just call from their cell phone, but you can. you use Doximity dialer. So you're still using your device, and then it's a free app. You just download it, super easy. You then have a HIPAA compliant platform to use with them, and you can, that the text is there as well. So we can do that. And then first, just make sure that you're talking to the right patient. Remember the HIPAA compliance. So you have to make sure that you verify the patient's name and their birth date, and don't leave messages. Just all typical things that we already know as docs. And then and I think this, it kind of it really was reminded of this because I was doing clinical research during COVID times, and this is what we did: is Doximity dialer. I remember just calling, and it's just so easy. The patients answer, it's very clear on your phone. Same thing. So that's the way to do that. And then also, as we're going to get to the urine tox screening, we're trying to bring ourselves to them, right?
Yeah.
Remember, we're trying to get to them, not really having them come to us or some clinic or some faraway place as necessary. So if we can do the tox screening, we even take that to them. So there's ways to do that. Somebody can go and collect it. We did this a lot during clinical research trials. It was no problem. Everything is obviously very verified. And then you could also have them go to like a testing center, LabCorp or Quest. A number of it, and then a Precision will give that that detail as well.
Yeah. So I know that we are going to put in the chat, but for those watching later, there is a company called Precision that offers a mobile testing. They are, again, we don't sponsor any individual person, but that is a SAMHSA approved partner that will do that. I know that Taylor's Clinic actually uses a place that does swabs by mail in the cheek that's called Millennium Lab. But I do want to dive a little bit deeper into this favorite topic of ours at Bridge, the urine drug screening, because we all know, to start, and Dylan, man, I'm going to call out your comment that you said, this was not a test designed for doctors. It just wasn't. It's not a medical test. It was actually originally designed to be used in the law enforcement community. And the sensitivity and specificity and accuracy of these tests is just trash in a lot of different ways, right? It's not a very good test. It depends on the drug that you're testing for, how long it's been since the patient has used that drug. So it doesn't usually have a role in emergency medicine. I would argue that it has next to zero role in my practice in emergency medicine. It's very rare that's a useful test for me, basically anytime. And I have yet to have a patient lie to me and say they use fentanyl and they don't. That has never happened to me. I'll be interested to see if that happens in the future, but it hasn't happened yet. And so it's just rare that that's even a helpful thing. However, in the clinic setting, this is like what I always hear the caveat, right? Is in the clinic setting, it's different. And now I want to think, okay, but I'm getting contradictory messaging. What I love is that all of you are kind of saying, I mean, yeah, whatever, we can do it. And I know we have champions that have been on our webinars before. I'm going to call Ed Pilar and Rebecca Trotsky. They talk about how it's a great conversation starter. But I've also heard of plenty of clinics that have rules about if you test a certain way, positive or negative, that this or that consequence happens to you. And so I just want to know, what's the real rule here? Like, is there really a rule? Is there a requirement to test people? If you're trying to start a clinic, what do you have to do? What do you recommend people do? And how do you make sure you're just not breaking rules, but not limiting access to care for patients in the meantime? Julie, let's have you continue since you're already on a roll on this one for me.
Oh, yeah, sure, no problem. So the most recent rules will be put up in the chat. It's a SAMHSA ASAM guidelines from 2017, but they were quite ahead of their times, and it's very relevant to us still. And it's always a ongoing changes are being made as we learn more and we get a little bit reduce the barriers. The role of testing it opens a conversation, as you said, and it's just really drug testing shouldn't be used punitively, right? It's a tool to support the recovery of our patients rather than punishing them. And that's something I still see even in our clinic sometimes, and we got to get rid of that. Really. So really the sorry, my my phone is being funny.
Oh, you're not, no problem.
Anyway, so really, we have to say, is it mandatory? So there's a lot of laws about that. Is it mandatory? It's in the clinic setting, as you said, it is different. But really, we don't fire the patients, we don't punish the patients. It's really example of when we need to kind of dig in deeper and get to the patient. Maybe they need more counseling, more therapy. Maybe it's a call for help
Yeah.
at that point, and then the most important is the self-reported information is really like what is the patient telling you, and hopefully by this point you've had a really good relationship with the patient, so it's open and they feel free to tell you like, hey doc, I'm struggling, I need to have a higher dose, let's adjust your dose, and just be open to do that. Sometimes there is a discrepancy between that, and that's just another opportunity for a conversation. We want to really improve their care. We don't want to just say, oh, we caught you, oh gosh, your drug screen is positive. It's just not okay. So, and then as far as how often, early on in recovery, it pretty much, in the very first visit for sure, sometimes then weekly, then monthly, and then it just depends on how mature they are in their recovery, and if they've relapsed, then you bounce back and you just kind of make a plan with the patient. Everybody's an individual. You can't write rules for every person that is going to cover everyone. So really it's just that it's an individual thing. That's why we're docs, it's medicine, we're helping them. It's a conversation back and forth. So as they become more stable, then it can get less and less. If they're abstinent for a long time, then we're talking like, let's do telehealth. We don't have to send the drug testing out there anymore. And you got to remember always, these are professional guidelines. It's not necessarily real life, and it's not necessarily the law. So if you feel like, hey, I've had a patient the other day, has a positive drug screen, is using kratom, is using all these other things, and it was like, oh, we shouldn't give them their bupe. And it's like, no, that's exactly when you should give them your bupe. I don't care how many years it's been they've been on it. There's no limit. If they're asking for it, they know their bodies, right? Then let's get it available to everyone. And then ultimately it's up to you and your comfort level, which you'll learn. Every inpatient encounter, you learn from that patient. And they teach us if you listen. So just, you have to have policy guidelines for your clinic, and that is always the thing. You have to follow, if you write it down, you have to follow that policy and adhere to it for consistency based, because you do have to have that. You can't be wishy-washy. And then make sure that when you're doing this policy, that it's patient-centered and not punitive. And then another thing is, you can share, like they say, why are you drug testing me, doc? You don't trust me? Then you just pull the guideline on and say, hey, this is why, and this is how we're going to support your recovery. And they usually just totally understand. It's never been a problem in the clinic for me anyways.
Yeah, absolutely. Maureen, I saw a comment that you put in the chat. Would you mind saying that out loud? Because it's so critical. Oh, it wasn't you, it was Melissa. But this comment about diversion, there's a comment. Thank you, Melissa. I misread your name as our wonderful panelist. But Taylor, I'm going to let you then address this comment that Melissa made. She said that she's getting a lot of pushback from doctors who think that they don't want to prescribe without looking at the urine tox screen, because what do I do if my patient's diverting?
Right.
And don't forget you're on mute, Taylor.
So I can say this from the emergency department perspective, where I also prescribe to patients in the emergency department when they come in, and I do the same as I do in clinic, and I write them for a month prescription. And people worry. I had multiple people tell me like, well, don't you worry about patients diverting? So I do it in the clinic and I don't really worry about them diverting there. I don't know why this would be different. The patients need treatment. So from that perspective, I don't think that's really an issue that I need to worry about. The other thing is, buprenorphine is vastly safer than the illicit drug supply. The drug supply is incredibly dangerous and highly potent, and so we don't know what's in it. And so if people are taking buprenorphine instead of fentanyl, then I would prefer that. That alone will save lives.
Yeah.
There's also data, and I don't remember the exact numbers, but some significant percentage of people who got onto MAT and maintained in terms of their abstinence from using high potency opioids started with diverted buprenorphine. So this is not an endorsement of diverting buprenorphine, but it is to say that that is not the worst thing that can happen.
Sure.
So that's one way that I address that. In terms of the testing, the only real reason that we are required to do drug testing by the DEA is for diversion, right? So the only thing I care about is if it tests negative for the thing that I'm prescribing them. In this case, often buprenorphine. But often those patients have a reason. Say they've been coming to me for a while. I haven't seen them in a few months, and they're like, "Doc, I ran out." Well, that's why their drug screen doesn't have any bupe in it. And that
Yeah.
means they need more. Not that I shouldn't be prescribing it to them because I'm worried they're diverting it. It's because they ran out of their prescription and they didn't have access. So
I love these comments. I love these comments so much. And what I want to say is if you have not seen any of our Bupe 101 kind of lectures, we do a little bit of a deep dive and show you anybody who wants to do some evidence on diversion that the vast majority of patients who are seeking buprenorphine from an illegal source are actually trying to be in treatment for something. They're trying to be out of withdrawal, in treatment, treat pain, treat depression. And so the right answer is treat people. If they can get their medicines from us, they don't need to buy it on the streets. When we say diversion, they mean somebody, getting their buprenorphine and selling it. And these are open, talk to your patients. And then please, for all these comments about urine drug screening, I do just want to remind you that there are certain state laws that we don't follow every single state. And so do check for sure if you're outside of California for any variants locally for you. But as far as the federal level national guidelines, the guidelines that we've shared with you are the only ones that exist, and they're just guidelines and there's no law. So doing a patient-centered approach is 100% the best way to do that. So I want to shift and talk about another topic that is very challenging, which I in the emergency department have the glorious privilege to basically not worry about ever, which is dealing with pharmacies. I think about the amount of headache that pharmacies cause me, and I only see a patient maybe once in their life. And I think about how often there are issues with patients coming to the ED with, not able to access their pharmacy. So I want to mention a couple of barriers that we hear specifically, and then I'm hopeful that we can have a discussion about how do you get rid of those barriers for your patients who are seeking ongoing medication treatment for their substance use disease or disorder, excuse me. For example, some pharmacies believe that there is a maximum dose of bupe and they will not fill it beyond 24 milligrams. I know that some insurances, like for us in California, Medi-Cal, likes to see a pre-authorization higher than 24 milligrams per day, but plenty of patients need more than that. Or pharmacies won't do longer prescriptions. They don't want to do more than like 2 weeks at a time. There's a lot of misunderstanding of the 72-hour rule, which I will clarify for everyone on this call, is an in-hospital situation where if a patient, let's say that you don't have a pharmacy open over the weekend where you live, like I work in a very rural place, patients can come back to the ED up to 72 hours in a row every day to get their medication, and we can legally give them their medicine in the emergency department. It doesn't mean that hospitals inside the hospital are limited to 72 hours or that pharmacies are limited to 72 hours. That's not a thing. It's just a in-hospital stopgap thing. So everyone misunderstands that rule. And then I've also heard a ton about pharmacies not having buprenorphine in stock. And there's these really strange existences of these like intermediary people, especially the big box pharmacies, where they just magically determine how many opioids this pharmacy will have and only this percentage will be bupe, and they don't want to carry it. And there's like these invisible caps that we hear about that aren't legally real, but that they exist. And so I am lost in this sea of unreal rules, but real limitations for our patients trying to access their medicine, which we know is life-saving and a critical part of their treatment plan. So I am curious what ways any of you have figured out how to make that process easier for patients, because I can imagine them being very discouraged and just giving up in the face of a lot of these barriers. Maureen, let's start with you.
Yeah, so we started actually with our own pharmacy. We actually have pharmacists that work in our bridge clinic. They literally double the number of patients that we can see. We have an, on-call doc like myself that can answer any questions for them. But by having them partner with us, we send all the prescriptions to our pharmacy when we can. Now they're not open 24/7, and some people like, it's more convenient for them to be able to go to a pharmacy near their area. So first I would advocate using your own pharmacy that you know and love, and you can develop that relationship. But if a patient insists on an outside pharmacy, one, the mom and pop shops tend to be a little bit easier. They want to have business. Our experiences, they're much easier to work with. But if you're having to use the bigger ones like CVS or Rite Aid, here in California, then trying to establish a relationship with at least, the higher utilization ones that your patients are using is good, but also making sure the patient is their own advocate. Let the patient know this is a controlled substance. You're only going to be able to be prescribed, 30 days at a time. As you progress in our clinic, we'll be able to do refills, but you're still going to have to go, to the pharmacy to pick them up. Some pharmacies will do, delivery, but you're going to have to establish a relationship with that pharmacy you're going to. Call them ahead of time. Don't wait until you're completely out. Because as we said, that particular pharmacy may have some stupid rule about not being able to carry buprenorphine unless they have to order it. So give them a couple of days heads up. Hey, I'm going to be running out soon. I'm going to be coming on Thursday to pick up my prescription. Can you please activate my refill so that it's ready for me to be picked up so I don't miss any dosages? It's really about that communication, and then making sure the pharmacy has your contact phone number, that they know this clinic is real, you see these patients regularly, and that they can call you if they have any question about the prescription.
Awesome. Julie, what about you?
So for residential facilities, we did this exactly. Just get the relationship with the mom and pop places, right? And yes, there's always problems they have to work on even with them, but they don't have the same regulations. The bigger box pharmacies have regulations, like you said. They have only a limited supply that they get, and they can't really make local decisions there. So their hands are kind of tied, even though they would want to help us in most times, which hopefully those levels will get worked on as well. But really, we use that a network of a few smaller pharmacies for the residential, and it works really well. We do that also for the outpatient, and then they can just call our clinic if there's any problem. I would say it's also important to know if they have films or tabs. Sometimes that's a problem, and sometimes they'll call you and just be like, hey, we didn't fulfill the prescription, and then you can say, hey, it's okay. Just make sure that it's okay to actually get that tabs versus the strips. Is whatever they have, let's take it, right? And then the local pharmacy they're just amazing to work with, and they really care for our patients. So I would say that is definitely the way to go.
Yeah, I know Rebecca Trotsky, one of our bridge champions, she has this like templated thing that she puts in all of her prescriptions to the pharmacy that says something like, yes, okay to substitute the box, like combination buprenorphine or plain naloxone, I don't care. Tabs versus films, I don't care. Like whatever you have, please fill it, call me if questions, here's my cell phone number. Like she has this like amazing thing that she just puts in there that is very direct, like we are filling this, and sends that message. Taylor, I'm thinking about your clinic specifically and how I know that you're in the Sacramento area, but that you serve patients who are a little bit outside the city. And I think those telehealth visits and their access to pharmacy care. Can you talk a little bit about that? Like in your clinic and your practice, what are you doing to deal with like the pharmacy issues?
So we have a number of patients who live like hours from us who have moved, maybe started with us years and years ago in the Sacramento area and subsequently moved more rural, and they're living in smaller towns and they only have one sort of like big name pharmacy, like a CVS or one of those. I was going to say Walgreens, but we'll see if they're still around. But I end up what I do with all of my patients, and especially with patients in these more rural areas, is I always check in on them whenever I have a follow-up visit on if they have any issues. And I tell them before they go, when they're new patients, to please call us if anything comes up. Sometimes it is that, well, they have strips but not tabs, and then the pharmacy doesn't want to fill it at all. CVS in particular, I've noticed at times their pharmacist will limit to just 24 milligrams per day. If we write a higher prescription than that, then they won't fill it. Sometimes it's a patient insurance issue. They'll only cover up to 24 milligrams. So if anything comes up, I just have the patients call us, kind of like Rebecca Trotsky says, like give them my phone number.
Totally.
My clinic line diverts to my cell phone after hours. So I tell them, like, you can still call the clinic number. It'll come to my cell phone and I will talk to the pharmacist there and then if you're having an issue. So it's really important to just be able to be upfront, have those conversations, be willing to have those phone calls sometimes, after hours. And talk to the pharmacist directly. It's really nice when like the executive director of my clinic has done an incredible job going to all the mom and pop pharmacies in the area and establishing those relationships. So we do have that. If we ever have an issue in our area, we know who we can go to. But when we're reaching people who are further away or have limited access, then it's really critically important that they get access to their medications in that limited pharmacy that they can. So being willing to sort of have those conversations with those pharmacies directly as sort of and establishing those relationships if you can, knowing that the patient is going to go to them and calling in advance or knowing that they'll need to order it. But
Yeah, I
especially
know.
that tabs versus
Mhm.
films issue
Right,
comes up frequently,
right.
having those
Right.
conversations too.
Yeah, absolutely. And we're not going to spend a lot of time talking about navigators on this chat today, but I do want to just call out, gosh, like the number of times that we've said having a navigator or a clinic director or your person at the front desk, like having a human being whose job is to be the easy access phone number for the patient. Like, hey, if you have a problem with the pharmacy, call me. Like, yeah, Dr. Nichols or whatever is busy with the patient, but I'm here. I'll answer the phone.
Yeah.
Like having those mechanisms in place and coaching our patients. I love having the question, how's it going at your pharmacy, being like one of the things that you ask routinely. It's a great pro tip. And now I want to be selfish for a second because as an emergency department physician, I believe the entire world revolves around the ER. And so thinking about all the work that we do, honestly, in the ED, and we do have a lot of emergency department champions. Dr. Baker, I see you. She's one of my personal friends, but there are a lot of us out here. We always coach our ED teams like, hey, you need to find a low barrier access clinic to do that middle branch, that middle pillar of bridge to connect our patients to ongoing care. But I'm curious about each of your experiences. Like, do you work with your local ED? Do you do the reverse direction? Like when you're setting up a clinic or you have a clinic, is there any going the other way? Like, are we in the ER just like lost on our own trying to find people like you? Or are you doing anything the reverse direction? And then if you are an ED champion, what tips do you have? Like a couple of basic pearls, maybe, that when we go to a clinic to find out quickly, is it really low barrier or not? What are a couple of things that we can ask up front to figure that out? Maureen, let's start with you.
Sure. Yeah. So I, work in the ER side and I have the MAC clinic side. So I think from an ER standpoint, what you want to do is like really look at the clinics that you're going to follow these patients up and make sure that we've talked about the low barrier. Make sure that they're a low barrier clinic. Make sure that they're not insisting on labs and urine drug screening. See if they allow walk-in. See if they have an ED or, referral process. Can they tap into your EMR? Is our website? You can just say, hey, I need this patient to get follow-up. Boom. Do they have, walk-in ability, just standing appointments on Thursday mornings where your patients can show up? Are they treating patients as human beings? And, being in Los Angeles, there is no regulations around this topic. I am learning. You can put your shingle out and say that you are an addiction specialist, and you can have a high barrier, you can have a lower barrier. You can believe in medications or you cannot believe in. You can believe it's religious or not believe in religious. So you have to be very, very careful about who you're, as we say in ER, baton passing your patients to. So do your homework and find out, what your clinics are that you're passing patients on to. And then as the clinic, reach out to ERs. We've reached out to ERs in our area. We have a great collaboration with correctional health because a lot of those patients were just, started on Suboxone while they were in custody and patted on the back, given a 30-day supply, not even, and told to find their own follow-up. So we've developed a really good relationship with that. So it's also reaching out from the clinic to the ER, making sure they have a good referral process, making sure they have your phone number. How does the ER get an appointment or understand how they get patients following up with you and developing that and giving them feedback too. I think ER docs like to know that what they do matters, and it does when patients have successful outcomes. So give them that feedback that, hey, you sent us 10 patients last month and a whole bunch of them are doing well. That's the type of positive feedback that they need.
Oh gosh, please give positive feedback to the ER. We get so much negative feedback.
Yeah.
I would love it if you could please tell us about the lives that we helped you to save. And speaking of things that I hate talking about, I want to bring up one more topic before we end today, and that is money. I believe that most of us who go into this kind of work, like this is not the era of going into medicine to get rich. Like that's not why we're here. But the reality is we do have to make enough money to keep our clinics open, right? And to staff navigators and to have all of these services that we want to have for our patients. Taylor, I'm actually going to ask you to start because I'm thinking about you describing the suggested schedule of the day at your clinic and that you're not, relying on a certain number of visits. And, given that we are a fee-for-service medical system here in the US, how are you making sure that this, like, without a doubt, patient-centered, human-centered, dream outpatient care, how are you making sure that you're able to stay financially feasible? And I want to be clear, we're not talking about getting rich. Like, no one's getting rich off doing addiction care. But how are you? Well, nobody should be getting rich. That's for sure. No one should be getting rich. But how do you make sure that you're able to keep your doors open and pay your staff well and, you know, do all of the things that you must do to function when you're really taking on this low
The
barrier?
biggest thing for us is that our clinic is a nonprofit. And
Ah,
so we get, so I'll plug it. That's why I'm wearing this. We get sort of funding from private foundations or private donors, from the state, and the city or county in terms of grants. So we are largely grant funded. Our clinical operations actually sort of we'll like break even on that, you know, on average. So that's not really what's paying our bills. It's helping us to pay rent and keep the lights on. But in terms of paying staff, and a lot of the work that we do, it's through that grant funding. The other thing that helps is, we do so we can, you know, take insurance. Some patients can't, use their insurance. For example, Kaiser they have their own addiction medicine and recovery services, but some patients don't want to go through their system. And so we have, a route by which patients can cash pay. So some patients, if they don't want to have to go through their insurance, they don't want it on their record, whatever, for whatever reason, that is an option that also helps us, you know, bring in more patients and helps to pay the bills. So those different sort of mechanisms by which we can keep ourselves funded are really sort of a critical point, in terms of the way we stay afloat.
nice. So I'm hearing if you can be a nonprofit clinic and think about things like grant funding, certainly even early on when you don't even have a patient base yet, like those items can be really critical
Yeah.
to getting started. And then of course, thinking about having cash pay options, accepting all insurances, things like procedural care, long-acting injectables, those things do bill better and they are patient-centered. And then, you know, you said this earlier, so I just want to call it out that when people don't show up, call them. When people
Yeah.
don't show up, call them. Have
You can
telehealth.
record those visits, right? If a
Right.
patient calls in and you basically schedule it as an appointment, and that is a billable visit. And like you said, I sort of neglected to mention, like, we have a brick and mortar building. Patients come to us, they drop in. That's a way not only to have local community, connections and outreach, and a way to get patients in the door who are seeking help and treatment. But also we can do long-acting injectables, which, you know, bill at a high rate. They are a procedure. They require that we are physically there. So and that we have the skills to do that. So that is a very, very useful aspect of doing what we do. And a number of patients, in our clinic are on injectables and find them incredibly useful for treatment. I'm a huge supporter of them, and I love that we do have this, brick and mortar facility, and then we have this sort of heavy focus on getting patients in the door, into treatment and sustainable treatment with injectables.
Yeah,
So that is a big, big way to help support your billing.
for sure. And so Maureen and Julie, I'm going to give you each 20 seconds to throw in any other thoughts you have about financial sustainability, because I know that's a really big question we get from a lot of people. Maureen, let's go you first.
Sure, I think recruiting from other areas, L&D, hospitalists, surgeons, putting up flyers, and utilizing staff that already exist in your facility. Pharmacy has been a huge advocate. They were
Nice.
already existing staff and they see patients in our clinic.
Amazing.
Right.
Julie.
So with Medical and some insurances, there is a way to make some money. So there's structured billing pathways for MAT education, a MAT initial visit, and then follow-ups as well. And that makes when the grants go away or they're not there for a while, you have to be sustainable, right, and efficient. So there's that, and then you just got to remember, beyond the reimbursement, I know this sounds like all dreamy, but offering MAT is such a powerful public health intervention, right? It reduces like long-term medical costs for all of our patients and social harm, right? And then similar to, you got to think of it, you said it before, is like the treatment of diabetes, hypertension, obesity, right? By making this care accessible, just like it is for those and without a stigma. we're not just helping just our individual people, but all of society. You got to think of the big picture, right?
Yeah.
So I think that's the most important.
Yeah, I basically think that there is no better way to wrap this up. So I appreciate you for saying that. I think if we don't carry the flame of hope and the dream and the mission, that all of us will just give up. And none of you gave up, and I don't plan to give up. And certainly everybody joining us probably doesn't want to give up. So you have dropped the largest buckets of knowledge on me today, and I want to do my best to do a very high level recap, and then we'll let everybody get on with their day today. And I'm so appreciative of everybody who stayed with us to the end. But first and foremost, remember, when we say low barrier, we mean patients being able to access care in a way that meets them where they're at. And we mean that physically, as busy human beings with jobs and children and sick parents and appointments and nails and whatever, like all the things that they are regularly doing in their life. We want to meet them there, but also emotionally, in general in their life, psychologically, like what do they need from us in that moment? And we want to be there to meet them with all of those things. And that means having a clinic, whether it's telehealth, brick and mortar, or a combination, that does that allows very flexible scheduling. If you're late, you can still come. If you miss, we'll call you. Like ways that we're gonna put you at the center of the care. Imagine that, you, instead of the structure that we've developed for you. And then having those flexible options and staff that are dedicated to helping remind patients, send them reminders about their appointments, call them if they miss it, tell them in advance, hey, your refill is going to be due in a week. Did you need me to help you call a pharmacy to get that thing in-house before you run out? And then making sure that, of course, number one, all patients have rapid access to evidence-based medication, because treatment is medicine, just like it is in every other chronic disease that we know of in healthcare. So putting medication first, bupe from day one, having really close ties to emergency departments so patients can follow up and not have a lapse in their prescription care. And then, of course, troubleshooting with your local pharmacy to make sure patients aren't running into barriers when they need those medicines. And if you want to start, you can do the Mo approach. You can start really small, like get a chair in the back of the urgent care and be like, can I use this on Tuesdays? And then just see patients, just see them. And it is okay sometimes to do it as you go and use the existing infrastructure that you have. Not everybody's going to be able on day one to open a clinic like Taylor's, like a brick and mortar or dedicated full service place. And that's okay. There's a lot in between those two. And so just start small, put a passionate physician in that chair or a PA, NP, pharmacist, whoever. Get them to see those patients. And then remembering that these models work. We have 3 examples of people who are doing financially sustainable, low barrier care. And it might take a little bit of an investment, hence maybe you start real small, but as it grows and you get that patient base, you are becoming a source of community, a safe space for your patients. And frankly, Maureen said this during the prep, and if you saw our advertisement for this webinar, like, I can't believe other clinics don't just do it like this all the time. Every other problem what people have with their healthcare. I'd be a better patient if that was the way that it worked. So if there's one thing that I really learned from all of our amazing guests today, it's that we really can do great things if we just try. And we can't let fear and all the regulations and the rules be too complicated for us to give it a shot. So like all those ads in the 90s, like just do it, right? I don't want to be brand loyal. Yeah, we certainly cannot wait for other people to come along and figure it out. This is on us. And by on us, I mean you and us. So if you have any questions, if you forgot every single thing that we just told you and you need to find it later, or you want to know, any other details or connect with one of our speakers, please reach out to us. bridge2treatment.org is our website, info@bridge2treatment.org. You can email that anytime and we'll get back to you. So please reach out to us. Let us know what you thought, what you need in future trainings, and just really thank you, every one of you, for all the things that you are doing to help us save lives. Have a great rest of your day.